Hello, I'm Dr. Alan Malik, and welcome to the second webinar in our series on how to boost your integrated behavioral health program performance. In this second webinar, we're going to get into how to simplify that screening process. And what we were able to show in the first webinar is what we're really doing here is we're kind of following C.J. Peek's model of medical settings and trying to look at how to make these more effective. So in the first webinar, we were basically in all the clinical sort of aspects of things of how to make that more effective. And now in the second webinar, we're going to get into the operational side of this thing. How do you make it actually work within the environment that you're looking at? And then finally, in the third one, we'll get into how to make that business case and get into all that financial aspects and the financial view. So let's get into it. What it comes down to is it's all about automation. My background is actually in robots and computer vision and all that kind of stuff, and it's amazing what you can do from a systemic level when you start automating things. So what we're looking at here, I mean the terms that seem to resonate with people is this idea of seamless integration, and we do that through automation. But there's different portions of that. So we're going to get into how the EMR integration components. There's a lot of misunderstanding about how that whole thing works and how you really want to break that out. We'll get into how to automate that patient interview. And then as a result of all this, you're going to enable much better patient management, better practice research, population, and quality management and so forth. So let's take a look. So how do we make it seamless? The big thing here is, if you go back to back in the early 2000s, it kind of followed a lot of Don Berwick's work through the Institute for Healthcare Improvement and so forth. And if you go through any of his management classes, he basically kind of comes back to, what do you do when you have a lack of a resource or basically you're under-resourced or you're under-capable and so forth. So you kind of look for other resources, other ways to make things happen. And in the medical settings, what you find out is that your patients are actually a resource. I mean, there's a tremendous value if you use them properly. And the biggest thing is, have them do your data entry. I mean, that's the thing that's getting lost when you don't automate properly. The patient with self-report sort of screening and so forth does all your work for you. I mean, it's just this tremendous piece of the puzzle. And so, the first thing about seamless is go directly to the patient, get the patient to do your data entry. Your next problem is, when you want to do that, that patient interview is, you're going to need some logic. You're going to need some ability to figure out how to pre-screen and then drop in or not drop in. What are the different areas that you want to be getting into? What are the measures associated? And those need to actually even be driven from the patient side in terms of the information you know about the patient. So based on age, or if they have chronic conditions, or if they're in an episode of care, these all kind of pop up, and you have to process through those to figure out what are the measures that you should be doing at any point in time, and then how do you integrate a bunch of those measures together to make it work together. Another part about making things seamless is the ability to not just screen in the office. You want to be able to do this stuff just as easily at home. And so, or on, send them a link or a text and get them to do it on their smartphone. But, open up your repertoire in terms of ways that you're willing to take information in and how to contact. And you don't necessarily need to be contacting only associated with a visit. You can do outcomes monitoring and so forth completely remote. You don't have to be doing it in the office. So, and, other things that come along with this whole thing is, you replace your hand calculations with the computer calculations. We see this more in the pediatric worlds and so forth, where the assessments are a little more involved and so forth. But when you're depending on staff to be doing those calculations for you, you're just introducing error and you have training issues associated with it. The other, next topic on this whole thing is, when it's electronic, you can route it anywhere. I mean, don't think of just having your data sitting in your EMR. You can have your data sitting in a data warehouse. You can have the stuff that the EMR wants sitting in the EMR. You can ship stuff off to a health information exchange. You can be putting stuff out into your own repositories. You can put it all on paper again if you want to. I mean, there's any combination of those sorts of things that you can do with your data. So, it's electronic. You just route it where you want, but now you can create all sorts of data stores. And then once you have, different alternative sort of bases, you can get at your aggregate information a whole lot differently too. But it's just a few more clicks. And it all started because you use that patient to do your data entry. So making this whole thing seamless starts right back with the patient. Is how do you get them involved in the process and put them to work. So let's think a little bit about integrated. So you're trying to integrate into a process. You're trying to integrate into a medical community in most cases. So you want to open up the breadth of that patient interview. I mean, you want to be looking for other stuff. It's not just about behavioral sort of issues. It's about the psych issues. It's about your pain. It's about your function. It's about all sorts of things that are going on. And you need to be, there's all sorts of screeners out there that allow you to get to that information, but you just got to kind of figure out how to group them all together and make that happen. And then you need to, from an operational perspective, you can't screw with the workflow. Everything has to go smoothly. You can't disrupt that whole process. So you need to figure out how to make this happen. Either if you're doing it in the office, you got to be respectful of that situation. You got to use technology that allows you to do that without interrupting much. And then, obviously if you can get it done through, outside of the office sort of activities, then that just takes the total pressure off of that workflow. And then we need to think about, you need to be obviously, number one is you have to be integrated to your EMR so the clinicians can get access to the information that they need. And we'll get into real detail about this because most people are not thinking about that EMR integration properly. And then obviously, you need to go beyond just the clinician sort of view of the whole thing. There's this whole patient management side of this thing. So most of you think about it in terms of registries and so forth, but we're seeing a lot more work around outcomes these days. So you got that outcomes, you got those registries. You start getting into, if you start getting into more community models, which we do a lot more in the early childhood sort of things, it becomes community-based, and there's a whole community access and a community network sort of concept. You need to think about this whole thing in terms of getting care coordination done and so forth. And then finally, you need dashboard access. So you can get at that aggregate information. So you can do your population management. You can do your quality improvement sort of things. You can get into grants. You can get into marketing information. You can do practice-based research. I mean, it's just, once you have all your information automatically electronically and unfortunately, I think you need to start thinking about it in terms of you need a data store outside of your EMR because you're just never going to get the depth of information inside your EMR that you're going to want to analyze when you start looking at dashboards and aggregate information. So, kind of build a system that can handle both. So let's dig in on this whole concept of EMR integration and kind of break it down a little bit and really kind of understand what's going on here. Because I think if you take a harder look at it, you'll start to realize most people are not thinking about the problem properly. So, obviously the first thing here is that you need clinician access to the information. So what does that really mean? Well, it comes down to, what information is the EMR going to manage? And it's not necessarily what the patient management people are looking at or necessarily what you want to do from an aggregate level. But those are specific clinical sort of things. So you want your PHQ-9s, you want your GAD-7 if you're using that sort of thing. You probably want your DAST. If you start getting into early childhood sort of things, you want to look at that communication delay. You want to look at what's their social emotional state. There's all sorts of different specific clinical sort of pieces that you want. And so those are the ones that you want to manage inside that EMR. But there's a ton more information that you're going to gather over the course of a patient interview if you're doing it well that isn't necessarily there. But figure out what you need from the clinical perspective. And then, the whole thing then becomes one of, where is that going to show up? How is it going to be accessed? And so what we see happening quite often is there may be a specific measure or two that somebody wants to have, and so they'll actually create a specific data field for it, which, that's a lot of work in terms of how you lay out your EMRs and so forth to put that together. But most people are basically just taking kind of all that data field sort of level information and really kind of rolling it up into a single node that basically says, oh, here's the measure, here's the score, here's the outer range sort of number associated with it, and this person's flagged in this particular situation. And we kind of run those out as essentially summary notes that can go out into the system. And so more often than not, you'll see that summary note showing up on that encounter tab. And then basically the clinician can look at it and go, oh, that was taken care of. Oh, something's out of line. And then you'll take the full report that's available with all the trending and all the other analysis associated with it, and you can basically bring that in as a lab document. So it's like getting the blood work sort of thing. You basically have got that analysis done and sitting on the report. So if something flags on your encounter tab, you drop down in and look for it in terms of your lab data. But it really comes down to where you're going to store the stuff, what information you're going to put in there, and it's a huge effort to figure all that out. And so that's, when people think about EMR integration, that's the component they're really thinking about is how do you get that, what data are you going to be managing? Where's it going to go? How are you going to get access to it? And it's the biggest part of the problem in terms of doing EMR integration is getting that taken care of. And so whether you're doing, the patient data entry by, staff over manual versus having a patient enter it and then bring it in via lab data through an interface, it doesn't, the problem is still there of what are you going to measure? Where's it going to go? And so it turns out, whether whether it's staff or whether it's patient reported sort of stuff, it still comes down to you got to have that fight of what is it going to be and where's it going to go? And so once you get that worked out, it turns out now it's like, okay, how are we going to get the data in there? So let's go over to the patient side of this, the patient data side of this whole thing. Well, the way your systems are set up now is that you're basically having staff do it manually. So it's a manual process. So you're still keeping, from an operational perspective, you're tying up staff. You're basically limiting out what you can get to because staff can't really do the assessment. So something like the QPD, they can't really create something like that for you. They can't pull that depth of information. So when you're limiting out what you can do in terms of the basic patient interview, screening or assessment, or however you want to think about it, computer assessment. But it's also then you have the labor of actually getting that data in. So even if you went to an outside system, had it go ahead and generate a report, pull up all the results, and then just have staff enter the result, the overall scores, or copy in a note or whatever you want to do, or import the PDF. I mean, you still want to use staff to manually get the data in there. At least they're not calculating anymore. They're not actually having to do the administration anymore. And then, if you're actually at the point where you're starting to use this information in a reasonable way and you've got it inside your EMR, then building that interface to actually go from a system like a patient tool sort of system where you can just shoot it in through as lab data. That lab data interface is actually easy to do once you know what you're trying to do. Though it's always the problem of what are you trying to measure, where are you trying to put it. But once you know that interface is actually easy. So when you think about integrating from the outside world, you got to look at, you're also saying I'm going to do all my administrations inside my EMR. That's not your best route, and that's going to basically take on your staff, and it's going to limit out what you can get to. So you really need to think about that interface. So it break it out as, it's patient data entry, and that's really where your problem is at, and you really want to solve that differently. But you definitely have, what everybody's talking about in terms of the clinician access and what information and where it goes. That's the core of the whole process. And so what you're going to find from this whole thing is that there's a bunch of data that you could use for patient management and for your aggregate data management and so forth that you may not want to manage all that inside your EMR. In most cases, you don't. So you really need to get into this idea of, let's get at a data warehouse and then put all our information into a data warehouse, whether it's a central sort of thing, like up on patient tools, or whether it's down inside your system. But the point is that you want to pull all your patient interview information into your data warehouse and then take the specific information that you need for the EMR and just pass it in as a lab result. That way you meet all the issues associated with the EMR and getting integrated into the EMR, but then you still have access to that data that you need outside for all the other sorts of things that you want to improve on. So with that in mind, then let's talk about automating that patient interview. So now if you kind of take the constraints off of that, it's got to be a simple form-based sort of thing that we can expect a staff person or some sort of form-based sort of concept to work on, then we can start getting into all sorts of measures. So we now say, let's say we wanted to measure 20 different things or 10 different things, even 5 different things. But each one of those has a ton of questions associated with it. And it's like, then when do you measure them? So what's that screening protocol associated with that? Well, what you should be doing and what you should be screening is actually driven by the patient's need. Where's the patient at? What's the age of the patient? Are they in an episode of care? Or da-da-da-da. So, all right, so you got plenty of things that you can be looking for now. And so it really comes down to a question of how do you limit the time, or basically limit the number of questions in either way. I mean, most, what we're seeing in environments is, you get up around 40-ish questions or, maybe 10 minutes of work. You're starting to push people's capacity for doing work and so forth. And to get to the kind of level of information we're talking about here, you're going to go way beyond that. So you start to have to get into ideas of how do you pre-screen, which is really kind of what we brought out in that study in webinar number 1, is that, you don't throw the big in-depth sort of assessment unless you need it, unless it comes up as a basically positive from the standpoint of a PHQ-9. But, you start doing that in all sorts of other areas. And if you actually even think about the QPD, the way it operates is it's basically just breaking down domains, digging in a little bit. If you get above a certain threshold, you dig in deeper. If not, you just move on to the next one. And that's kind of how you need to start linking all these different types of measures together. So it becomes very logic-based. And so, pretty quickly you see that it becomes a computer assessment. I mean, that was the same, was basically the problem with the QPD and why we ended up putting on a tablet in the first place back in '95. But the situation is still the same now. If you want to get to that better level of information, think of it like a computer assessment. It basically, what you end up doing is you basically say it's too complex to be administered manually. So when you're setting up your EMR and expecting your staff to do your data entry for your patient side, that's kind of not a very good way to go about doing your business. So anyway, moving on. So once you get these better levels of information, and you also start to see that there's a lot of this information that isn't really being, it just doesn't make sense to be running it through your EMR. It really does get to this idea. If you want to get into that depth of information that you can do in a patient interview, you really want to get to this idea of sticking it in your own data warehouse so that you can store and access it for other purposes like better patient management and so forth, doing your outcomes, doing your registry and your care coordination and so forth. But then just transact into your EMR the data that you need for the EMR and that the EMR wants to manage. I mean, obviously that is the number one reason for pulling data and so forth. But if you basically think about it as let's store it in a centralized sort of data warehouse concept and then just transact in what the EMR needs, then you've got a much richer source of information and you can do much more with it. And, right along the same lines as the patient management, it's the exact same sort of thing when you go to the population and quality management. I mean, if you want to do those outcomes, you want to do that practice-based research, you want to do those grants, you want to do all that other stuff, once again, it's your patients are your resource. They're going to enter all your information for you for free. It's going to compile everything up. Now pull from that everything that you need for that population and quality management. So once again, shift your focus over from the EMR is not your central point for your patient data. Put it into a data warehouse, transact into the EMR what the EMR needs, and then you've got this rich store of information that you can do all this other work with. So just some ways to think about how do you solve your bigger problem of meeting all those clinical needs and so forth. So, getting down to a little more brass tacks in terms of how do you actually do these things. So, the whole idea here is we're trying to simplify this process. So if we're doing EMR integration, obviously everything's going in as a lab result. And so we've already talked about using a summary note, or specific data fields, or the overall report. And, that's just standard, HL7, everybody talks HL7, it's an ORU message, and you can just define them. It's a simple message to push through. And even in terms of the newer JSON and so forth, type of file message formats, you can just push all this stuff through. So it's common. I mean, people take lab data all day long, and that all you need to think about your patient interview as just another piece of lab data. So I just kind of switch that from a systemic perspective. And then the thing that we found is that generally on labs, you're ordering lab data. And so that's not really the way you want to handle screening. So what you really want to do is you want to go over to that scheduling feed. And so what we do in most of our, probably the last 4 or 5 years worth of EMR integrations, we basically take the scheduling feed and we put it onto what we call a launch list. And so the idea is in that outbound scheduling, and we can even take ADT message if you need it. But what ends up being is in that scheduling message, you're getting out in that the patient PIDs. What is that? Well, I don't know what that acronym is. Remember what that is? But basically, it's your patient data. So you can pull that out, and it comes in automatically. And now you have complete identifying information. So when you send your lab data back in, there's no confusion about where the data came from. But you're also going to get out your visit type. And the visit location is going to tell you which clinic you're in. And so now from those two things alone, usually you can queue up the protocol directly. But you can also pull patient information that's inside the system that's been recorded previously and so forth to know where get a better feel for where you should be adding your protocols and what information you should be looking for. But all that logic associated with that is then put into what we call configurable screening protocols. But basically it's data driven by that specific patient, and then pull back in and said, oh, okay, now here's what we're queuing up. And then, you can schedule these things out on the launch list. It's coming from the EMR. So even if you're going to go and do like an at-home sort of thing, you can actually schedule it up and say, 7 days before they show up or before the visit, shoot them an email or shoot them a text and try to get that information at that point. If it's not back within, by 3 days out, then you can turn around and send them a reminder. I mean, you can automate that entire process of getting information in. And then if they don't get it done before they show up at your office, then you basically redirect that launch out onto a tablet in your office or redirect it out to their smartphone when they're standing there in front of you and have them go fill it out. I mean, it's getting information is actually a lot easier than you think now with modern technology and all our social media and basically internet connected world. So, just start thinking about better ways to get that information in. So then, the workflows, I've kind of hinted at these, obviously the thing is you can't mess with this sort of thing, but there's this whole concept of the in-office workflow and the at-home workflow. And I kind of alluded to how you can actually, basically go from your EMR out. But you can also put, components like patient management sort of pieces in the office that would allow you to actually direct out for those remote sort of launch concepts where you're basically saying, get it done before you show up at the office, or direct them inside the office. You can, inside of those, and then if you don't want to get to that level of intervention there, you can actually even do them right at a tablet level. I mean, we have a lot of systems where all they want to do is just enter the ID and it will automatically go back and check, come down with the first name, last name, date of birth, and then the staff can say, oh, okay, that's really who it is. Let's hand the tablet off and just have it automatically queue up whatever they're doing at that particular location. So you can get this all the way down to, you can start implementing with just a single tablet, and all you do is enter the ID and the system works. So, there's all sorts of different ways to launch in the office or at home, any combination. But the neat thing in terms of that whole thing, though, is that once you get that out of the staff person's hands in terms of getting it to go, then the patient's doing all your work. All your calculations are done for you automatically. Everything is completed and pushed into the EMR for you automatically. All your data entry is done for you automatically. So you're not really, all this extra screening that you're doing, you're really not interfering. In fact, it's less staff involvement to do the full up automated sort of thing than it is to go out and administer, say, a PHQ-2 or a PHQ-9 and then have to score it and enter it. All we're really saying is pick up a tablet, worst case, enter an access code, go look down a launch list, find the individual, hit them, and away you go. If you're doing it, if you're basically launching from your EMR and you get it done remotely and back in before you show up for the visit, there's literally no impact on staff time. And so you've basically taken all your screening stuff and moved it outside the office. We see that a lot more in pediatric environments and so forth. But this whole idea of how do you automate everything and just simplify to the point of worst case, you pick up a tablet, enter an access code, hit the individual and verify, and away they go. So anyway, all this automation does great things for you, and it really simplifies that whole operational side of CJ Peek's world. So basically, once you got past that, then we want to spend some time exploring this third view, which is this financial, which is really, it comes down to you got to be able to cost justify what you're doing, and you need to be able to make that argument to management and so forth. So we'll get into that in making the business case in webinar number 3. So if you would kind of page down there and maybe leave some comments for us, and you should find the link for webinar 3 down there as well. So thank you very much for your time, and hopefully we'll see you on webinar number 3.